In occasione del congresso Osteoreumatologi che si è tenuto a Genova, il dottor Piet Geusens ha tenuto un'interessante relazione in cui ha riportato nuovi dati riguardanti l'osteoporosi e in particolare la terapia di questa malattia. Dottor Geusens, cosa c'è di nuovo riguardo l'osteoporosi?
Firstly, we have a lot of new data about all drugs. For instance, about estrogens. It has been shown that combined hormonal replacement therapy indeed prevents bone loss and bone fractures. However, there is a lot of side effects. And because of that, a recent economic evaluation showed that since patients stopped hormonal replacement therapy, indeed there were more fractures, but there were less side effects such as breast cancer, deaths, and cardiovascular diseases. What is new about anti-resorptive therapy? Well, when we look to what happens in bone after the menopause and osteoporosis, most patients will have an increased bone resorption. So the first group of drugs we use in treatment of osteoporosis is anti-resorptive drugs. And the main group of anti-resorptive drugs is bisphosphonates. And for bisphosphonates, we now know that it is the standard therapy in most patients with postmenopausal osteoporosis. A new development has been denosumab, which is a monoclonal antibody against rank ligand. And compared to the classical bisphosphonates, it is a very strong inhibitor of bone resorption and bone formation. And in that way, it decreases the risk of hip, vertebral and non-vertebral fractures. One of the advantages of denosumab is that it is given 2 times subcutaneously per year, which has been shown not only to be preferred by patients, but also result in longer and better persistence than, for instance, weekly alendronate. We have now data about long-term fracture prevention with denosumab, so after the FREEDOM study, the incidence of fractures remained low, even during a follow-up of 8 years. Now, for bisphosphonates, we normally evaluate the patient after 5 years to see if we can stop the treatment if the risk is low, or continue the treatment when the risk is high. However, for denosumab, when you stop this treatment, it has been shown after 2 years stopping that indeed the bone gain that has been achieved by treatment is lost within 1 year because bone resorption increased immediately. So it is unclear how long we should treat denosumab, and if we imagine to or decide to interrupt treatment, how long we should interrupt it. This is a question that should be further studied. One of the new anti-resorptive drugs is odanacatab. Odanacatab is a selective inhibitor of cathepsin K and in that way decreases bone resorption. And indeed it has been shown that it increases significantly the bone density in the spine and in the hip and in the femoral neck, even up to 10%. It does it by decreasing bone resorption and decreasing bone formation, but this decreasing bone formation is only temporarily. So after 1 year we see that bone formation goes up again, and this is an example of a drug where there is a disconnect between the bone resorption, which is decreased, and the bone formation, which is initially decreased and then goes up. What is the effect on fractures? Well, up until now we have only meta-analysis of the phase 2 trials, and they indicate, based on the incidence of fractures as an adverse event, that indeed odanacatab can decrease the risk of fractures. Recent data in the ASBMR in Houston have indeed shown that there is a significant decrease in the risk of hip, vertebral and non-vertebral fractures. So odanacatab is a new drug which indeed has a different mechanism of classical anti-resorptive drugs and which will be further studied and probably be available. However, in elderly patients we see also patients who have a low bone turnover, and this is a special group of patients. And for this group of patients we have the second group of anti-osteoporosis drugs, which is the anabolic drugs. And anabolic drugs indeed, as the name suggests, indicate that we can build new bone. And the first of the anabolic drugs is parathyroid hormone, or a part of parathyroid hormone which is teriparatide. And teriparatide has been shown to increase bone resorption, but even more to increase bone formation. While this increased bone resorption and formation are coupled, indeed teriparatide has resulted in new bone structure, in bigger trabeculae, and so not only increasing bone density but also bone structure, and resulted in a significant decrease in risk of vertebral and non-vertebral fractures. Teriparatide has a special action. It increases the production of rank ligand, increasing bone resorption, and it suppresses sclerostin, which is an inhibitor of bone formation. So by inhibiting an inhibitor of bone resorption, it stimulates bone formation. What is new in this field? In this field we have now also studies in phase 1 and 2 studying the effect of a monoclonal antibody against sclerostin. And there are two of these products in study, which is blozosumab and rozosumab. It has been shown in phase 1 and 2 studies that these significantly increase bone density, and for blozosumab and rozosumab we have some data that there is increases higher than for alendronate and is higher than for teriparatide. So how does this drug act? Well, if we look to the bone markers, we see that antisclerostin immediately increases bone formation and at the same time decreases bone resorption. So here we have a drug where there is really a disconnect between bone formation, which is increased, and bone resorption, which is decreased. And indeed, the disconnect of this action can explain why antisclerostin has a bigger effect on bone density than other treatments, as I discussed before. So in summary, I think we have, with the new insights on bone remodeling and the new developments of anti-resorptive drugs and anabolic drugs, we have indeed new data that show us that in the future we can better help the patients to prevent fractures and probably better individualize treatment for these patients.